Welcome. Today we're delving into a critical aspect of care for lung transplant recipients: rejection. When a new lung is introduced, the body's immune system can sometimes identify it as foreign and attack. This attack, or rejection, primarily manifests in two major forms: acute cellular rejection, or ACR, and antibody-mediated rejection, or AMR. While both are serious, they are driven by different culprits within the immune system and require distinct approaches to diagnosis and treatment. Understanding these differences is key to protecting the precious gift of life. Let's start with acute cellular rejection, ACR. Think of ACR as the more traditionally understood form of rejection. Here, the primary aggressors are T lymphocytes, or T cells. These are specialized immune cells that directly attack the cells of the transplanted lung, seeing them as invaders. Imagine them as foot soldiers on a direct mission. Clinicians often look for signs like shortness of breath, cough, or a drop in lung function tests. A definitive diagnosis usually comes from a lung biopsy, where pathologists will see these T cells infiltrating the lung tissue, particularly around blood vessels and airways. Treatment for ACR typically involves stepping up the patient's general immunosuppression, often with high-dose corticosteroids, acting like a broad counteroffensive to calm these T cells down. ACR can be graded by severity, and while often treatable, recurrent or severe episodes can lead to chronic problems. Now let's shift to antibody-mediated rejection, AMR. This is a more complex and often stealthier adversary. In AMR, the troublemakers aren't cells directly, but rather antibodies, specifically donor-specific antibodies, or DSAs. These antibodies are proteins produced by another type of immune cell, B lymphocytes, and they specifically target antigens present on the cells of the donor lung, particularly the lining of the blood vessels, the endothelium. So instead of a direct cellular assault on the lung tissue itself, AMR is more like a targeted strike against the lung's vascular system. These antibodies bind to the blood vessel walls, triggering a cascade of inflammation, complement activation, and damage to these delicate structures. This can lead to capillaritis inflammation of the tiny capillaries, and can sometimes be seen on biopsy with special stains like C4D, which indicates complement activation. Diagnosing AMR is a bit like detective work, requiring a combination of evidence of DSAs in the patient's blood, specific biopsy findings showing microvascular injury, and clinical signs of graft dysfunction. So, what are the key differences to remember? First, the culprit, T cells in ACR versus antibodies, DSAs in AMR. Second, the primary target, lung tissue and airways broadly in ACR versus the blood vessel lining, endothelium, specifically in AMR. Third, the diagnostic clues, lymphocytic infiltrates on biopsy for ACR versus DSAs in the blood, C4D deposition, and specific microvascular injury patterns for AMR. And finally, treatment approaches, general immunosuppression escalation for ACR, while AMR often requires more targeted therapies to remove or neutralize the harmful antibodies, such as plasmapheresis, intravenous immunoglobulin, IVIG, or drugs targeting B cells. AMR is often considered more challenging to treat and can have more severe implications for long-term graft survival. Distinguishing between ACR and AMR, or recognizing when both might be occurring, is crucial for tailoring the right treatment strategy and giving patients the best possible outcome. Vigilant monitoring, sophisticated diagnostics,